Dr. Hassan Abdel Salam, who is going to talk about pre-treatment assessment of PAE, clinical exam, imaging. Thank you.
Thank you, Mr. Chairman, for the presentation and for the organizing committee for the kind invitation. This is a quick presentation regarding patient selection and pre-assessment before prostatic artery embolization. So the first assessment is clinical assessment, where you assess the patient. We do the IPSS score, and then clinical assessment in clinic with the patient to identify the obstructive symptoms or irritative symptoms, length of the symptoms, previous medications, and then ultrasound scan in clinic to see the prostate anatomy, prostate size, post-voiding residual, identify if the patient had any events of acute retention, failed therapy or side effects of therapy, and then decide whether this is a suitable patient for embolization or not. The International Prostate Symptom Score is seven questions to be asked to the patient, and then the patient will select his answer between 0 and 5, and then the score is calculated. The questions are incomplete emptying, frequency, intermittency, urgency, weak stream, straining, and nocturia. And the score is calculated and then graded into mild, moderate, and severe. So 0 to 7 is the mild form, 8 to 19 is moderate, and 20 to 35 is severe form. Ideally, you should select the moderate to severe patients for prostatic artery embolization so you can get the best outcome, and obstructive symptoms rather than irritative symptoms. Also, we do the quality of life score, and we ask the patient, if you were, it's just one question, if you were to spend the rest of your life with these symptoms, how would you feel? And the answers are between 0 and 6, starting with delighted to terrible, and of course we do the indication if the score is 3 or above. The labs, we do PSA, total, free, and ratio, and then in some cases we need to do MRI or biopsy. If everything is fine with the PSA, we normally don't do MRI or biopsy, of course. Renal functions, it is an essential test before giving the IV contrast during the embolization. Coagulation profile, urine analysis, and if there is infection, then we proceed to culture. And in some cases, I mean, when we started doing embolization more than 10 years ago, we used to do the uroflowmetry in every case. But now we are selective if we think that the patient has got weak detrusor muscle activity. Again, MRI pelvis in selected cases where the PSA or the ultrasound scan is doubtful. So this will give us idea about the volume, medial lobe, the anatomy, the intravesical prostatic protrusion, and of course to exclude cancer or confirm cancer. Different anatomical consideration we can detect from the MRI. This is the lateral lobe enlargement, and this is the median lobe enlargement. I'm not sure, but personally, with these cases, I'm not sure about the panel here. With these cases with the protruding median lobe, we sometimes don't get effective results as the other cases. I'm not sure about your feel about that.
Yes, the median loop adenoma responds less compared to the lateral loops, and you should tell the patient about this before doing the procedure. And in the literature, some papers say that if the vertical dimension of the protrusion inside the urinary bladder is larger than the horizontal dimension, it is better to avoid to do. However, you can do, but you tell the patient that the response may be less compared to the lateral loops adenoma.
Yeah, do you want?
I agree. You have a comment? Please go ahead. So I agree with you. One thing that you have to say about just hypertrophic median lobe is that, like, this process is not huge. Just to remove the median lobe, that is probably the cause of most of symptoms, is an easy treatment by TURP, and the side effect of it is not that bad. So sometimes you have to compare the alternative, and if the alternative is better, I would go for that.
Yeah.
Depends on the size of the pedicle. Sometimes it has a specific artery going to it. If you have a French catheter, you can go to this median lobe and embolize it. I have some cases like this. It usually, if the pedicle is most of the time it will improve as well. I agree. You have to tell the patient this. I agree. You have to tell the patient this might be of little efficiency. For a case like this, the one on the right, yes, definitely. But sometimes the pedicle is big and it is a median lobe adenoma, and it improves a lot when you embolize it. And also the embolic, because I've seen when you use glue and you do it on level 3, you go very distal. I'm not sure Hisham uses lots of glue, so maybe he would say yes or no to this. It usually shrinks a lot.
Yeah, I mean, personally, I mean, I've seen cases like this one, which I usually discuss it with the patient and tell him that this might be an insufficient result in this case. If surgery is feasible, then I would recommend surgery. If the patient refuses surgery for any reason, or his comorbidities disallow surgery, then he needs to know that we might not be getting the same results as usual with other cases. Contraindications: cancer, overt prostatic cancer, or active UTI until treated. Relative contraindications: neurogenic bladder, and in some cases you have to treat the obstruction first, but tell the patient that you will need some medical treatment after the prostatic artery embolization, or you might not get what you think you're getting from prostatic artery embolization because of the neurogenic bladder. Impaired renal function: if not treatable, then you can't do it. If treatable, then it's relative contraindication. So what are the predictors of good outcome? Moderate to severe symptoms in IPSS, predominance of obstructive symptoms rather than irritative symptoms. The larger, the better, so size matters. The larger prostate, 80 or above, or 100 even. We've done cases up to in 200s and reaching 300 cc. The larger the prostate, the better result, or the difference in symptoms. Again, the median lobe is debatable. Preserved bladder function and absence, or patient is not on a long-term indwelling urinary catheter. Again, this affects the bladder wall function. And what we expect the IPS to be improved, the volume reduction to 30%, 30 to 50%. Ejaculation, I mean, when we first started 11 years ago, we used to tell the patient that we never have any retrograde ejaculation or an ejaculation, although we had a patient, one of 300 patients that I've done, had an ejaculation. And I think when I asked other colleagues, it happens. I don't know why, but it happens. If you have any explanation why it happens?
Some of the patient had already some medications that cause retrograde ejaculation before embolization. And even if they stop, sometimes it doesn't get back.
Okay.
So that's why in the surgical series, sometimes they don't give the right number, because they say, does it occur retrograde ejaculation after surgery? They say no, because they have already retrograde ejaculation. So I don't know if the patient had already some kind of medication before, or some
maybe.
retrograde ejaculation. So
Maybe he had medications, of course, but he didn't have retrograde ejaculation. He had it just after embolization. It was only 1 out of 300 patients.
It's been reported. It's not very common.
Yeah. And of course, retreatment rate is 5 to 10% in 3 to 5 years. So the take-home message is patient selection and counseling the patient. These are the key to successful prostatic artery embolization. Thank you very much.
Thank you for this great talk. Thank you. And now